Okay, hello. Welcome to the VIVA's Friday Night Fellows. It's a special CNI webinar that we're doing with a presentation that's consistent with the VIVA strategies on the front line. Again, I want to remind you that VIVA is a not-for-profit organization and dedicated to education. And one of the things that's going on with this COVID pandemic is that many people aren't as busy as they usually are. And I think it gives opportunities to review things and go over cases and hear from other people around the country. We obviously do that together, but it's nice to be in an environment where we could potentially hear from other people around the country. So thank you for joining us. It's going to be an interactive webinar. Several CLI cases are going to be presented by our VIVA panelists, and we encourage you to be engaged throughout by answering polls and sending us questions at any time during the live event. This event is being recorded and will be available later as well at vivaphysicians.org. To answer a question, to ask a question to our panel, please click on the Q&A tab that's on the bottom of the menu and put your question in. Window will pop up, and it's fairly simple. Please don't use the chat because we won't be monitoring the chat, but we will be monitoring the Q&A. And we will launch polls throughout the webinar, throughout the case presentation, so that we can you can select an answer and we can see what people would do and what was actually done. I'm going to introduce our panel. I'm Nitin Singh. I'm a vascular surgeon at Harborview at the University of Washington here in Seattle. Sarah Sabri is my co-moderator, and he's an interventional radiologist at MedStar in Washington, D.C. Our panelists today are Vinita Chandra from Stanford, sitting with the Four Seasons background behind her, and Aaron Armstrong, an interventional cardiologist from the University of Colorado, and Peter Schneider, a vascular surgeon from the University of California, San Francisco, but I think he's in Hawaii. It looks like he's in Hawaii with his background and his shirt. And
what gave it away? What gave it away?
Exactly. And with that, why don't we get started? I'm going to turn it over to Sarah and Vinita.
All right, Vinita, let's get started with your first case. And there'll be some polling questions, so when the poll comes up, I'll ask you all to answer. Vinita, go ahead.
Okay, can you guys hear me now?
Yes.
All right, well, thank you guys so much for having me here. I have to say for many years, Friday evenings are actually my block time. So it's quite exciting that for once I'm not struggling in the OR all night, but I'm excited to be here. And this is, I think, hopefully will be an interesting case. It's somewhat straightforward, but somewhat interesting, and a case where I learned something just recently. So I'm gonna go ahead and get started. All right, so the patient is actually a nun. She was a 76-year-old woman who'd had really long-standing wounds in both feet. The one on her left foot, which I'm not going to be focusing on, was over 8 years old, and she had a new one on the right side that was about 10, 11 months old, and that's what she came to see me for, well, for both of them, since she'd recently moved here from the East Coast. She lived in a convent and actually had pretty good care. She was primarily in a wheelchair to avoid pressure on her wounds and had home health with dressing care. She had a past medical history that you would expect: hyperlipidemia, diabetes, this history of chronic osteomyelitis, primarily on the left side, peripheral vascular disease, etc. And you can see her medications here. So this is what her right side did look like. Her left side was quite the disaster as well, but we're going to just focus on the right for today. As you can see, this is a medial foot ulcer with a really pale base. It's around the first metatarsal joint there, with a fair bit of callus around it despite her non-weight-bearing status. And then, see here, this is her arterial evaluation. You can see clearly has evidence of peripheral vascular disease with monophasic waveforms and evidence of SFA pop disease, as well as probably multi-level disease with ABI of 0.43 and 0.52. So I took her. Oh.
Peter, before going to the angiogram, is this your routine test that you order prior to CLI cases? You do usually a Duplex and ABIs and TBIs. Is that what you go to, or do you do any other imaging?
Yeah, no, that's pretty much exactly what I do. We do have capabilities for TCOM, et cetera, but really I usually find enough information between the waveforms and TBIs, if not ABIs. I don't know if any of the other panelists have a different pathway.
Peter or Aaron?
That's what I do too. ABI, TBI, very simple, good for triage. And then when I've established it may be a vascular problem, I typically would get a duplex. Doesn't mean right or wrong. A lot of places have great CTA readily available or terrific MRA. For me, duplex has been probably our best quality approach.
Yeah, and I think it's reproducible in most places, right? But TCPO2s can be sometimes a little more difficult to get.
Aaron, same?
Yes, actually, starting with physiologic studies and then using a duplex is my go-to as well. You know, I think a lot of patients with critical limb ischemia have varying levels of chronic kidney disease. So I feel the duplex also can be helpful for figuring out what you're getting into without exposing patients to additional contrast, because typically they need to get a subsequent angiogram fairly soon.
All right, Lenita?
Sure. So I'll go ahead. This is her angiogram. You can see she's got fairly just diffuse calcified disease everywhere, not necessarily obstructive in a lot of places, but just, you know, those unhealthy vessels pretty much everywhere. You can see a widely patent common femoral and profunda. And then as we go down a little bit further, you can see this really bulky sort of exophytic high-grade sort of distal SFA popliteal lesion here, which I would say is definitely clinically significant. And then if you go below the knee, here we go. This is her angiogram here. So you can see, again, very diffuse disease. Perineal is really her only runoff with some TP trunk disease. There's no sign of a PT that I could find anywhere approximately, and a pretty dismal looking AT2 that occludes. In her foot, you can see here, her perineal is quite robust with fairly significant collateralization and reconstitution of the medial plantar, as you can see, with even a blush. So this is really quite chronic with good collateralization, but obviously not good enough to heal a wound.
Yeah, you have quite the occlusions here in front of you to deal with. So so first, did you start with an up and over axis rather than antegrade? Is that?
You know, I did. So that's a really great point. I usually, very often with critical limb ischemia patients, as you know, they're usually infrapopliteal disease. So I almost always go antegrade. With her, because she had that evidence of SFA disease, and I knew it was mid SFA and down, but I just wanted to make sure I had enough running room to manage that if I needed to. So I did go up and over on her.
Benita, there's a question from the audience too. If there's a lesion at the common femoral artery, do you puncture it or do you go contralateral and cross over? Let's say you knew that there was a lesion at the common femoral and you wanted to go antegrade. Does that prohibit you from going directly at it?
Yeah, I would say if I knew of a lesion in the common femoral artery, my whole algorithm changes a bit. I usually then definitely get a CT angio and assess the aortoiliac segments in general and see, what I'm dealing with and whether or not I need a femoral enterectomy or iliac management before proceeding with an angiogram.
Yeah, I agree. I think sometimes you don't know what the external iliacs are going to look like if you got heavily calcified commons and in that scenario. Thanks.
No problem. So this is just a little summary. This is a very classic, I think, wound patient, right? Multi-level disease with a right medial first toe wound. And then we just went through obviously the lesions that she has, and there's several of them. So I'm going to keep going because there's a lot of work to do. But I'm going to stop, this is our first poll. So I'm going to pause here. I guess I'm supposed to read the poll. Is that right?
Yeah, please do.
And you guys are going to put it up? Okay, so the poll is, what should we do now? Stop because the perfusion is adequate, or ABI was 0.5, so it wasn't horrible, and just continue wound care. Choice 2 is to proceed with endovascular attempt of the SFA and POP only, since her perineum was so robust with collateralization, and leave it at that. Choice 3 is to do endovascular repair of the SFA POP disease and the tibial disease, and then choice 4 is to plan a bypass to that medial plantar artery for definitive repair.
So we'll ask attendees to answer while we discuss this. Peter, what do you think? Is this would be a good option to do a bypass, or would you try to go after both or one lesion?
You can't really disturb me right now. I'm voting to make sure I put the vote count. No, I think to me, this is a great case for endo because you described a woman who is primarily wheelchair bound. She may need something even more extensive on her other leg. Even though she's got diffuse infrageniculate disease, her actual lesions are pretty focal. So on this one, I would like to go for endo and then maybe remeasure her foot perfusion and follow her clinically. Although it's got a heaped up sort of edge around the ulcer, it doesn't look horribly deep. We don't have any evidence that it's in the metatarsal. So those would be at least some initial thoughts on where I'd kind of go with it. I'd probably only use bypass in this case as an absolute backup, because you got to argue really in a non-ambulatory patient, is it appropriate to do a long leg? It'd be a bypass probably to the common plantar would be my guess.
So I think only 2% of people think you need to bypass. All right. So the majority say they want to go for both lesions. Aaron, is that what you would do? Go after both lesions, or just do the SFA pop only?
Yeah, absolutely. In this case, I would go after both lesions. I think to Peter's point, these are calcific and highly calcified lesions, but they are relatively focal as well. And I think that given that the perineal is the only runoff as well, I think that, in my opinion, you need to treat both the SFA healing here.
Yeah, so it seems like the consensus mostly has been to go after both lesions, try to get as much straight line flow to the wound blush, not just treat one area. Unlike claudicants, the algorithm could be different. All right, so Vanita, what did you do?
I went for it endo, as you can imagine. So let's go ahead here. So this is the first lesion, and I wanted to pause here just for a little bit because I think this is a good teaching case. It seems really simple, right? It's really focal. It's really short, but actually I think oftentimes these are the ones we take a little bit for granted and can get into trouble if we're not careful. I really try to stay true lumen in a really bulky plaque like this, and I think you can. I think there is a tiny little true lumen path, and so if you sort of slow down just right above it, and I usually switch down to an 014 or an 018 platform, and then try to just delicately get across it so as to stay true lumen. I don't know if anyone else has different strategies, but I do think it's worth thinking about for a minute before just going after it.
Yeah, what would you cross, Peter, a lesion like this? Do you stay 035 or do you switch to?
No, I like what Vanita's talking about. This is one place where in the SFA going 014 makes an impact. And I think what I would probably be doing is backing it up with a catheter, going down, taking a very magnified view to see, is there a secret passageway where I can get my command 014 or my fielder wire to just dance right across that stenosis, stay true lumen. Sometimes you need some obliques, or maybe, I wouldn't belabor it, but if you don't have to knuckle the wire, your likelihood of getting a more straightforward result in a case like this, I think, is higher. The other thing is that right distal to that lesion, our eye is drawn to that tight lesion. We know that's the hemodynamic part, but the artery just distal to that looks terrible. It's got these big eccentric type cauliflower lesions that if you go subintimal above that, you're not coming back for air anytime soon. So staying true lumen is, I think, it's worth the extra minute of time to do here. So I agree with your approach that you elucidated so far.
Aaron, does also what you're going to use affect what method you're going to cross? Like if you think in doing atherectomy, you want to start true lumen?
Yeah, absolutely. I think I would definitely take some pains to stay true lumen here if at all possible. I think it helps keep options open with regards to subsequent atherectomy, if that's the route we're going to go from a lesion preparation standpoint. I think, to Peter's point too, if you do knuckle a wire here and end up subintimal, this could turn from an above knee intervention to something where you don't re-enter until you're below knee. And that could have a lot of implications for, both surgical bailout potentially, and also, where you have to put some scaffold and being across more of a flexion joint. So I think staying true lumen here, probably with an 014 wire and an 014, 018 support catheter would be my go-to approach.
Yeah, I don't think that could be, restated enough. I think that in that position with the artery, the way it looks distally, is that you can just get yourself in a mess being subintimal right there. And, those are the ones with the poor runoff and the nasty popliteal where, that could be turn into a long day.
This is one, incidentally, where if I did get subintimal and I couldn't get back in, I would use a reentry device rather than sticking a compromised single vessel perineal that only has collateral runoff. Just a thought there.
That's exactly. I mean, you're close to the knee joint, so now this is why you have to be very careful if you re-enter just above the knee joint if you have to. But let's see, Vinita, did you manage to get through this?
I did, and I like, you know, those hydrophilic coated 014 wires. I used a Hydros too in this case, and I really find it will find the tiniest little track, and so I was able to get across that. And then I got to the below knee, and as you guys remember, I'm just going to show it. You have this bit of TP trunk disease, really no sign of a posterior tibial, which you could argue is the primary angiosome runoff to that area of the wound, and then this AT that was really just crappy looking and dwindles off pretty quickly. And so this is our next poll, I think. I'm just going to say I did wiggle around and try and truly could not find any sign of a PT, if you're wondering. So this is why I limited the poll options in terms of what would you like to do now. And here are your choices. Retrograde revascularization of the PT through a medial plantar artery puncture. Balloon of the TP trunk only and get out of Dodge. Revascularize the AT and attempt to get around the pedal arch, or nothing more. Assuming that you're going to obviously treat that lesion we just passed.
I mean, I think these are all a lot of great options. So knowing that the PT, and you spoke about the angiosome, that where the lesion is, it seems to be kind of on the medial side. So getting a PT would be good, but you have a very good peroneal with good connection there. But you need more to go to the plantar vessels, and going after the AT seems reasonable. Aaron, would you do the same? Would you go after the AT as well after ballooning that the lesion higher up and the TPT?
Yeah, I mean, I think it would be tempting to do that. You know, it could also turn a relatively straightforward case into a very long slog. And so, you know, I think you could make an argument here for potentially ballooning the TP trunk only and get out, which I think it looks like 27% of people agreed with. But I think, you know, this is where I think we need more data as well in CLI with regards to when is enough, and, you know, when are we getting adequate perfusion to the wound, because that's what really matters here in this case. And so I think to that point, revascularizing the AT and attempting to get around the pedal arch could be a good option.
You know, Aaron, I couldn't agree with you more. I think that this list of options that I've given you are all absolutely appropriate. You could argue any of them, quite honestly, and that's what's tricky about CLI. And I'm thirsty for a technology that really adequately and effectively will help guide these decisions. I mean, if there was a technology that says this is enough after you balloon the TP trunk, wouldn't that be great? And we could stop that long, lengthy case that we keep trying and trying, and we've all been there.
Also, just very, very briefly, let me just add that this is where your knowledge of the patient and whether or not they're compliant and what their general joie de vivre, if they really are gung-ho to get this done or not, because normally what I would do is treat the stuff that's the low risk. If I know for sure the patient will be compliant and come back, you know, you could treat the SFA and TP trunk, remeasure hemodynamics, follow the wound. And if you run into trouble, then you do something more. I would consider trying to get open an AT that ends in an artery that you can't see in the foot. I would consider that, you know, kind of an exotic sort of tertiary level plan where something simpler might work if it's a patient that could fit with that kind of possibly a two-stage plan. Just a thought.
Let me ask you also, would you try to cross any occlusion distally, you know, attempt going after the AT after you treated the fempop lesion, or you do cross, get the wire all the way down, then go back and treat the fempop lesion? So it seems like that sequencing is also very important. I feel like it's probably better to treat the fempop lesion, get it out of the way, and if you want to shower or anything like this, you still occlude it distally, like that's like a natural filter, rather than crossing everything, get everything open distally, and then go back and treat the SFA. And now if you shower, all the stuff going to the foot. So I feel like doing stepwise from trying to treat the lesion more proximal to distal before crossing.
And also I did see, and Vinita, you'll have to correct me if I'm wrong, but I did see a short segment of AT at the ankle. but I didn't see any extension into a DP on one of your previous films, or what I thought was a short segment of distal AT at the ankle. So there may be more vessel there than we think. You know, it's hard to tell because the flow is compromised. But the other thing, just what Sahar said, I'd be tempted to use atherectomy in that focal lesion in the SFA. And in that case, I definitely don't want to open up the distal and then go back and do atherectomy. So I would like to use, you know, I would like to do it in a stepwise fashion, just the way he described.
So there are questions from the audience. Just to, and you can probably get to it as you move along. But one is, what is the best management if you get a dissection in the TP trunk, as well after ballooning? It didn't appear to be responding to prolonged ballooning. I think those are things that we could probably discuss. And another thing is it pertains to the therapeutic mode that you're going to be doing. So I think you're probably going to get to these questions. So the audience is chiming in with good questions right now.
Yeah, I think that's a great question. Why don't we move along and then we can make sure we remember to address that. I didn't do what, you know, Sahar and Peter so wisely said. I just got excited for the tibial stuff and just kept working. But I pretty much always, well, we'll talk about that later. But anyway, so I gave the AT a whirl. And quite honestly, with quite a bit of finesse, but ultimately using an 014 wire again, as well as a CXI, I was able to cross. And this isn't the best shot. There's a little bit of bubbles in there, but you can see actually, Peter, you were right. I do think that this AT right here was actually patent, and then not the greatest pedal arch look here, but certainly something, and it was going straight to the first toe, so I thought it's worth a try. And so in the interest of time, I'm just going to keep going. So I angioplastied that AT, and this is what it looked like proximally, and then this is what it looked like distally. And I thought, that's weird. So I'm much happier with the perfusion to the foot. The AT looks brisk and, you know, keeping time with the PT, but it just occludes again somewhere down in the foot. And I'm like, gosh, is it thrombus? You know, what did I do wrong? Scratching my head here. So I do a little, check my ACT, put a little intraarterial nitro. I ballooned it again, and it still looks like this. So I'm just going to pause here and see if anybody has any thoughts.
Was this during your Friday night block time?
Of course.
The question is usually when you lose an artery. I mean, this happens so frequently, whoever do CLI. I mean, whenever you lose an artery in the middle of intervention. So the question is it spasm? Is it dissection? Or is it recoil or thrombosis? And now to treat it, you have to pretty much try all of the above. You give nitro, you check the ACT, you re-balloon, and then you potentially give TPA if you think there's thrombus. I mean, these kind of, and you know, you probably have be a good judge of what you're dealing with to decide which of these to do, or you have to do all of them. What do you guys do when you lose the artery?
Yeah, another thing that I do think is helpful when this happens sometimes is to then put a very small support catheter all the way down distally and then do some hand injections. You know, for example, put down an 014 support catheter and inject just a half a cc. And that way you can see what the outflow looks like. And then you can walk the support catheter back, you know, a few millimeters to 30 or 40 millimeters, then do another injection. And that can help really localize the area where you may have a severe dissection or recoil or spasm. The disadvantage of that potentially is you could lose wire access, but in general, I found that that's been very helpful in diagnosing exactly what's going on and where.
I like that trick a lot, Aaron. I use it a lot. Keep the wire and puff, you know, with a bigger catheter, hold up to see what's going on. All right.
Yeah, I think these are all great selections, and these are really, I mean, it's a frustrating situation, right? You've done all this work, and so I tried everything. You know, I thought maybe it's a spasm. I tried the balloon. I don't think I used any TPA, but I did take a bigger catheter down and aspirated. And then I went into my sort of repertoire of prior experience and of going to lectures, I think somewhat like this. And I remembered, I think it was Peter one time taught me about this.
Usually it's Peter.
Which is, there's this thing, and I don't know what we call it, whether it's like pseudo obstruction of the anterior tibial, but you can have this basically compression with the extensor retinaculum at the ankle. And so I literally just went and flexed her foot. And then I got this much better angiogram. It's not, again, the best quality angiogram, but you can see filling, and even if you can see closely, a little blush at the end at the wound. So I was pretty jazzed, and I thought enough is enough. I'm gonna move on. Any thoughts here? Anyone else see this?
You know, Vanita, I think there was something, maybe it was at the Western, it was presented last year about this anterior tibial artery compartment syndrome, where they had a little aneurysmal degeneration just past it and had to release it, and had a nice video of it. But yeah, no, in doing that, I think we've all kind of seen something similar to this, because we've done all the maneuvers you do, and then all of a sudden, maybe it's a patient's foot that moves, and you get it back, and you're like, hey, let's get out, let's stop. But it's probably this, exactly what you're talking about.
Peter?
It's very interesting. I would just going back to what you said before about TPA. I in a situation like this, I do what Sar said. I just assume it could be any of the above and kind of work through. And it takes a long, time to get TPA. And usually TPA is more of a threat. Like if you ask for it and you say, mix it up, go ahead, hopefully you'll be done by the time the TPA is ready.
Exactly.
I would just, what was that?
You never inject it, you just ask for it.
Exactly. You use it as a threat. And no, so, but I don't have anything to add. I mean, I've seen this a couple of times. It's kind of weird. We don't really have a way to, assess for this. I've never gone and divided someone's extensor retinaculum thinking that I was going to help them, but just realizing it's a dynamic process and they've got their foot in a certain position while they're on your table. It's very interesting though. And I know I've seen it a couple of times.
And the whole flexing and extension of the foot also helps a lot if you're doing trying to cross a lesion, at the ankle level, or doing a pedal loop, doing flexion extension helps a great deal to kind of stretch a vessel to help with that. So, all right, Vanita, so did he then go after the SFA pop, or just look at it?
So I'm going to just kind of whisk through this in the interest of time here. But yeah, I treated the TP trunk, and this is just a completion of you can see nice now 2 vessel runoff at least.
And sorry,
going down.
If you have a dissection of the TP trunk, how would you treat it?
Oh yeah. I mean, if prolonged inflation doesn't work, I'm not opposed to using a focal short coronary drug-eluting stent in that spot if it's really flow limiting. I don't know what other people think.
Aaron, is that what you use for focal?
Yeah, I think.
Oh dear.
Yeah, we lost your voice a little bit there, Aaron. But yeah, I mean, I think coronary stent, drug-eluting stent, or a put. Are you back, Aaron?
Yeah. Can you hear me?
Yes.
Okay. Yeah, I think coronary drug-eluting stent is a good option, especially if it's a shorter area of dissection or recoil. I would point out that just a few weeks ago, the below-knee TAC was approved as well for treatment of infrapopliteal dissections. So that would be actually a potential option now for treating a dissection below the knee.
Yeah, I agree. It'll be a great use for it here. All right, so let's go to the SFA lesion now. Okay,
so just as a reminder, this is what it looks like. And then there's another poll. So how would you guys all treat this SFA pop lesion? And there's a lot of choices here, so I'm interested to see how it gets distributed. But POBA alone, DCB alone, a bare metal stent, including a vasculomimetic stent, a stent graft, drug-eluting stent, lithoplasty, or atherectomy, followed by one of those other options.
All right, so let's quickly go around. Peter, what would be your choice here?
Okay, so if I did this up front, I would probably treat it with atherectomy plus a DCB. Now that I have this very delicate distal reconstruction that I don't want, I've already done what I think is the hard part. I would try to keep it simple here. And that probably means a stent for me. I want to finish the case. I don't want to spend a lot of time exercising myself. It is inflow for a long, slow flow artery. So I would probably end up with a DES above the knee there, SFA.
Aaron?
Yeah, I think those would be good options. I mean, I think with any concern about runoff too, I think using intravascular lithotripsy would be a good option. We know that causes very low rates, if any, of embolization and would help potentially limit dissection in this calcific lesion. And then depending on what that looked like afterwards, then I'd probably use a drug-coated balloon or a stent.
Yeah, I would do it exactly the same as you, Aaron. And if the stent is needed, use one of the vascular mimetic device like Superior stent. So it seems like most people are thinking of doing atherectomy and then afterwards go after. But the warning will be, as Peter mentioned, since we opened the vessel, you need to use a filter or something like this. So, all right, Vanita.
Yeah, so I will say that I went for atherectomy, and I think it's really because it was so focal and just so bulky, and I don't think any of the other technologies would work great just on their own. I'm not going to go into the details, but I personally thought directional atherectomy, and I used the Hawk1 device, would make the most sense because it can really debulk a bit. And that's what I was hoping for. And I sort of I use atherectomy particularly, exactly for this kind of lesion, focal, really bulky calcified plaque, and particularly an area that I don't think is optimal for a stent. And then just really quickly, we had another poll about filters. And I think we already talked about this a little bit. And I'm just curious how people sort of manage when they atherectomy. Filter almost always, almost never, or just occasionally. Thoughts, panelists?
Yeah, I think it depends on the device. I think some devices definitely always a filter. Some other devices like CSI, I don't use filters at all, but most of the others I would use a filter. And the lithoplasty, the advantage is you don't need a filter.
Okay, so most people are filter almost always, and I fall into that category. And I think particularly, we've all been, or at least the vascular surgeons in this group, I'm sure, we've all been inside blood vessels like this, right? Where we've seen that really just friable, almost granular appearing plaque. And so I'm almost always use a filter when I use atherectomy, but particularly for this kind of looking plaque. So I put a filter, as you can see at the bottom of my screen there, in the distal pop. And I'm just really sort of slowly and carefully debulked, and then followed with a DCB. And this final picture I think is important to look at. And one of my favorite lines when you end up like this is that you can't make chicken soup out of chicken beep. And so, there's certainly still some plaque and disease, but I think at this point, flying through pretty well. And I think I've definitely increased sort of the pressure head to the lower leg, and I can always come back for more. So I'm not super aggressive about making this look perfect.
That's I think that's pretty awesome. You've answered like numerous questions that have come up from the audience as well about atherectomy of filter wire. There's one more question, is using coronary stents down in the foot a crazy option? I think in the tibials it's probably appropriate, but I don't know, in the pedal vessels, I think it's not a very great option.
The
Anybody
answer
else
to
on
that question, in my opinion, is yes, it's crazy.
Yeah.
The patients, and to the extent that we do have data, there is a little bit of data on stents below the ankle, and they fare miserably.
I've never used them below the ankle ever. It just doesn't seem to make sense to me.
Yes.
This is
It looks like your filter had some material in it. On
oh my God, it was completely full. I actually forgot to mention that. It was full, and it was full of exactly the kind of stuff that I was worried about, but thank goodness it was in there. And I didn't try to squeeze it out of a catheter. I just pulled everything out at this point, and took a follow-up check, and everything was fine. I realized I didn't put that one in there, sorry.
Excellent.
And then you can see just much, much better perfusion. I'd been sort of carefully debriding that wound before I revascularized her, because I'd been dealing with her left side first, and she was just pale as pale could be. You can see just much better perfusion. I'm hoping she'll heal this up pretty quickly.
This was awesome, Vanita. And just one last question for follow-up, other than clinical follow-up for wound healing, do you do duplex at a certain times, or just for these CLI patients, or you go with the TBIs or just the wound healing?
I'm pretty methodical, I should say. I guess I like to check on them very regularly. So for CLI patients with active wounds, at least every 3 months, unless something changes in terms of the wound care. I personally see my own wound care patients. I have a sort of a once a week wound care clinic. So I actually personally can judge it. So it makes it a little bit easier. So if they fall off trajectory, I immediately catch it. But if they aren't being seen by me, then I'm pretty diligent about at least every 3 months, having some evaluation.
Excellent.
One last question from the audience, and it's what is the preference for atherectomy catheters below the knee? Aaron, you got I know you've got quite an experience with atherectomy below the knee as well.
Yeah, I think below the knee, we know that the tibial vessels do tend to have more overall calcification and long diffuse disease in many circumstances. And, a lot of the other atherectomy catheters are also sized so that they're more effective in the SFA or popliteal. So my usual go-to if I'm using atherectomy below the knee is orbital atherectomy. I think with the 125 microburr, you can get all the way down below the ankle safely. And I think, parenthetically, I think that the rates of embolization when you're doing atherectomy below the knee seem to be lower. And that may be because the vessel behaves differently, or you're not dealing with as many kind of bulky boulders of calcification that tend to break off.
Yeah.
No, sorry, Vanita, go ahead.
Oh, nothing. I was just going to say I still use directional atherectomy. I guess I'm somewhat selective about when I use atherectomy. I'm usually sort of for bulkier plaque or focal lesions, and so I find it just really effective, and it's my typical one that I use, even for below the knee. All right, I'm going to stop sharing here unless there's any other questions.
Excellent. Nitin, I'll get back to you to go the next case with Aaron.
Great, that's fantastic, Vanita. All right, Aaron, let's hear about your case.
Alrighty, can everyone see my slides there? Great.
Yes.
Okay.
Although we can't hear you too well.
Peripheral. Okay, can you hear me now?
Yes.
Okay, good. So this patient had a history of severe claudication, and he actually underwent bilateral common iliac artery stenting in 2012 for treatment of that claudication. Unfortunately, he developed recurrent claudication in 2014, and at that time it was noted that his iliac stents had occluded. He therefore was treated with a surgical option where he had an aortobifemoral bypass. And I'm not entirely sure why, but the left limb was grafted to the profunda with a jump graft from the profunda to the proximal SFA at the time of that surgery. The right limb was actually grafted directly onto the common femoral artery. And that anatomy, I think, plays a role in the subsequent case. But then, unfortunately, he presented to me and had developed breast pain over the last 4 months. So there was concern that there had been some progression, either as native disease or something that had occurred to his bypass graft. So from a hemodynamic and duplex assessment strategy, we talked about this on the last case, but we tend to do physiologic studies in duplex for both triaging and determining what things are going to look like angiographically. His right ABI was still normal, it was 0.92, but his left ABI was 0.65 with a toe pressure that was 39 millimeters of mercury. And duplex ultrasound demonstrated a patent graft to the left, from the left iliac to the profunda, but it appeared that the limb that jumped from the profunda to the proximal SFA had occluded, as well as the ongoing SFA itself. So it appeared that there was potentially either an issue with that graft limb or that he had progression of his own native SFA disease leading to occlusion back up proximally. He did, however, have a patent popliteal artery and monophasic but non-occluded infrapopliteal signals.
So Aaron, just to ask you on this one, we're talking about preoperative studies. I think sometimes when we run into this problem, this is where I think additional imaging, particularly on somebody who's had a proximal aortic kind of intervention, is valuable. Did you not get a CAT scan, or was that not part of your algorithm on this one?
Yeah, no, that's a really good point. I think in general, when you're dealing with aortoiliac disease, especially, I think getting CT imaging can be very helpful from a preoperative planning perspective. He had some mild chronic kidney disease. His creatinine was around 1.4. And honestly, if where I practice often clinically at a VA hospital, it takes a few weeks to get a CAT scan. It's actually easier to do an angiogram than a CT. So for that reason, I tend to rely pretty heavily on duplex and not preoperative CT imaging.
Gotcha. I didn't know that. I thought Denver was a little forward thinking.
Yeah, they generally are, but not the radiology department for one reason or another.
All right.
Be careful. I know people there.
We'll come to your first polling question.
All right.
Yeah, so it looks like people have responded here. I think that the trick is that, between the aortobifemoral bypass graft and this jump graft, the question is, how you'd want to image this from the beginning, as well as how you'd be able to actually access from a treatment perspective. So right femoral retrograde is an option. Certainly by doing that, you could do a pigtail injection and be able to see runoff down the left leg. The difficulty there is that it's unlikely that you're going to be able to cross over through the bifemoral bypass graft in order to do any kind of intervention. That is possible sometimes, depending on the exact anatomy, and you can use some fancy equipment like a deflectable sheath in order to do that. But I tend to try to avoid doing that in most of these cases because it ends up making the case more difficult. Left femoral antegrade is definitely an option. The issue with antegrade access here potentially is the scar tissue that can often occur after a bypass graft in that setting. And then also the question of if you're landing within the graft hood itself or within the native common femoral, which honestly can be a little bit difficult to tell on duplex at times. Retrograde tibial would be an option, although I think it would be kind of an aggressive option from the get-go, especially in the absence of CT imaging with regards to determining exactly what's going on from the inflow perspective. And then it seems like we have a tie here for left brachial and left radial. The advantage of left brachial, of course, is that you're a little closer to the target lesion, so you should be able to reach down potentially into the mid-SFA with currently available catheters and techniques. And then left radial is an option too. That would help with the imaging. Treat from the radial. We do have some newer devices now reach farther down from a radial access perspective, but we still have a lot of limitations with regards to the other adjunctive therapies.
So what about the panel here, Peter, Benita, what do you guys?
I would have gone, I said to go through the radial because unless I was sure I was going to treat. So if I was thinking this is an angio and possible treatment, I would probably go brachial because then I would have a 6 French access that without, with a percutaneous hold. If I just had the sense like I just need a good angio and think about it, I would go radial because then it preserves that brachial in case you want to come back a week later. I would stay out of the groins here. If I did puncture the right femoral, I'd be puncturing a prosthetic graft, which you can do, but it's just like another thing. Probably not great for closure devices. So you go in with your 4 or 5 French. And if I did do that, I would use probably a Simmons 1 shape and just hang it hook shaped right on the aortic bifurcation, but you can't get proximity, as Aaron said, and most of the time with an aortofem, unless it's a really wide upside down V or it's a degenerated graft, they're impossible to get across without every maneuver. And frankly, for diagnostics, why go to that kind of trouble? So I would have stayed out of the groins and gone to the upper extremity with the algorithm that I mentioned.
Anita, you agree?
Yeah, I would. I completely agree. I think I would almost for sure probably just go brachial, just because it's hard for me not to think I may want to do more. But yeah, I would stay out of the groins for sure.
All right, Aaron, what'd you do?
Those are all really good points. In this case, I did choose to go left radial as the access. Since we didn't have the CT imaging, as Peter mentioned, I wasn't entirely sure what we'd be getting into and whether we'd stop and stage something. And so just avoiding the initial brachial access. The downside, of course, being that from the radial access, probably wouldn't be able to definitively treat anything. But I thought that this would be a good approach to get the initial angiography and then decide, would it be necessary to use brachial access or potentially some kind of a retrograde option more distally to come up retrograde. So here's what the initial angiography revealed. You can see here, this is the pigtail catheter coming down from left radial, sitting here in the distal aorta. You can see the aortobifemoral bypass graft. You can also see an outline of the prior stents here as well that had been placed. You can see actually on the left side it extended down to the left external iliac. And then I think you can appreciate that on the right side, the graft plugs into what appears to be a very high bifurcation, and then ongoing SFA and profunda. And then on the left side, it appears that the profunda is patent, and there's a nub here that's either the nub of potentially the jump graft segment or of the native SFA. So then just going on down here further.
Aaron, that may be your answer as to why they went to the profunda, right? Because that stent extends pretty distal, and your common femoral, when that went down, may have been, you know, when you try to endarterectomize those things, they can become pretty thin, and they may have had to just take it right to the profunda, and that's why they did that and jump graft to the SFA.
Oh, that's a really good point. Yeah, that would make sense. Yeah, that probably was the reason in retrospect. So you can see here just a little bit more magnified view of this nub here into what, you know, is presumably where the ongoing SFA would be. The reconstitution here was in the distal SFA, just above the adductor canal. You can see the collaterals coming in from the profunda here with what appears to be a really, you know, moderately diseased distal SFA, but relatively normal caliber and relatively disease-free popliteal. And then the ongoing infrapopliteal vessels, you know, on Duplex looked like that they were monophasic but patent. It was hard, honestly, to get a good image from above of the runoff vessels initially, just because of the extent of the lack of major collateralization, but it appears that there's probably 3 vessel runoff as the Duplex had suggested. And then just trying to get an image initially of the foot, it appeared that the posterior tibial was probably the most dominant of the runoff vessels. You can see that imaged here relatively well with less robust outflow through the AT and perineal. So that's what the baseline angiography looked like. So the next question I'd like to ask everyone is that, you know, I initially probed the jump graft with a wire and a 150 navicross from above, but it was pretty clear to me that with radial access, first off, we weren't gonna be able to reach all the way down to the reconstitution very well from a treatment perspective. And also the wire just wasn't going well from above. So it appeared we need some kind of other access. So what would be your next approach?
So
Grade
I'll
left.
ask the in and out a little bit, Aaron, with the audio, but I'll ask the panel while that's going on. Anita, what would you do? You're muted.
Yeah, I would probably try either retrograde distal pop or distal SFA. I think being closer to the occlusion is beneficial. Try to get across.
Yeah, Peter.
Okay, so I'm going to break protocol here and just say this would be a pretty easy above knee fem pop. I think one option would be to come from the aortofem limb above. It's 2 incisions. You know, you have to decide, is the patient young enough that you're worried about using vein? He does have rest pain, which, you know, in my opinion, rest pain sometimes is more urgent than Rutherford 6. If the patient's had an open chronic wound for a long time, it's not changing much. And you definitely want to do something before this person develops tissue loss. To me, I think if you're thinking open, you could do it on the information that you have. If you're thinking endo, I would go with the retrograde SFA as my first choice.
You know, it's interesting. I'm sorry, Sarah, go ahead.
Yeah, I'm just saying, I mean, you can do either pop or high AT access is a good access that you can then angioplasty afterwards. I think that's a good option. And for the popliteal, I mean, I've had cases where you end up in a hematoma that's hard to control, and it's hard to hold pressure there or, you know, balloon against. So it seems like the high T axis seems to have potentially be less of an issue. So these are the 2 options available.
Yeah, we you know, it's interesting, in our pre-op conference today, we were talking about a case very similar to this, and we talked about a technique that we had described years ago about just making an incision for a below knee pop, exposing the artery, and just going retrograde that way. And if you get through, you stent, then it avoids a redo groin and everything else. But, you know, I agree with Peter. It's fairly straightforward fem pop kind of bypass, or trying to do it from a SFA or popliteal approach. Aaron, would you?
Great. I think those are all really good points there. I think that it looks like the majority of the audience voted for retrograde tibial, which I think is a reasonable approach if you're going endo. However, when I am crossing an SFA occlusion retrograde, if there's an option to access a little more proximally, I think that does help for a few reasons. One is you have more pushability generally, gives you a little bit more options as far as using 035 crossing wires. And then you do have the option of using a larger sheath if you want to in those cases as well, with kind of less potential risk to the smaller tibial vessels. So in this case, I opted to go with retrograde SFA access on the left. The advantages of retrograde SFA access are that you can treat the patient in the supine position, effectively in many cases eliminating the need for popliteal access and having to put somebody prone. You can also use larger sheath sizes if you need to. And then the disadvantages, of course, of retrograde SFA access is that it's relatively non-compressible. It is possible to put a large blood pressure cuff on at suprasystolic pressures and eliminate hematoma. And it can be challenging to access in obese patients because you do have to tunnel down pretty far through the subcutaneous space in many of these cases. And I thought it would be useful for a second just to go over this because people in the audience may not have done this as often from a technique perspective. If you haven't read it, there's a really fantastic paper by Andre Schmidt published in the Journal of Endovascular Therapy that describes this technique in detail and their experience with the initial 50 cases. So when you have the patient in the supine position, you access medial and in the ventral thigh, distal to the adductor canal, just a little bit above the patella when you're looking down at it. And one nice technique trick that I often use here, because you have to go relatively far, is you can use a very long micropuncture needle, the one that is typically used in a pericardiocentesis kit, and you can place it through or inside an 18 gauge Cook needle. And this helps improve the stability of the micropuncture needle so that it's less likely to bend when you're going through the subcutaneous tissue. And then this is almost always a fluoroscopic guided technique because it's often relatively deep in the SFA and can be hard to visualize on duplex. But you want to line up with a contralateral oblique to line up the artery. So if you're accessing the right SFA, you go LAO. And then I think the key with this technique is you have to go contralateral and assess the needle distance from the vessel. And the few times that this you go in too straight down with a needle and then have a low enough slope coming in with a wire, you can get kinging of the wire at the access site and then have difficulty putting in a sheath. And then from a hemostasis perspective, there are a few options. Assuming you're successful with the procedure and are coming down from above, you can always do intraluminal balloon occlusion. Usually in these cases, what I do is at the end of the procedure, I get protamine, and then I put on a blood pressure cuff to about 10 to 20 millimeters of mercury above blood pressure, systolic pressure, and then inflate that for 10 to 15 minutes. And that generally results in pretty good hemostasis. So I just thought I'd ask the audience too, since we've got a group of primarily fellowship trainees, what their experience has been with retrograde SFA access, whether it's never 1 to 5, 5 to 10, or more than 10 times.
Peter, you didn't get to answer that one.
The number in my fellowship was 0. No, I was just going to say, so 2 things on this worth mentioning. One is that you could also puncture the occlusion directly in this case, since he's got an SFA occlusion. And then if you're thinking fempop, and you can do Nitin solution of cutting down there, and then, you get a wire through and do the fempop if you don't. But if you're worried about, oh gosh, if I do a fempop later and I've just punctured that artery, you can just puncture the occlusion directly. But in this case, what I would be worried about with endo is that you would get through, because you're going to get in the occlusion and you're going to get retrograde up the artery. And the question is, how do you find that blind and completely occluded bypass that somebody did, the little jump graft? The good news is it's short. The bad news is it's at some crazy angle. I mean, that's not something we normally do. We don't do that operation what this patient had. So there must have been something going on, like Nitin suggested. Anyway, just a couple of thoughts as you're working through this.
Peter, there's a question here from the participant. Have you used a PQ bypass? Is that an option here, or if anybody else has used the PQ bypass in here?
Okay, so Aaron actually probably has more PQ bypass experience than anybody else here, but I'll just say my 2 cents is that you don't have a clear line of sight to the inflow. So the answer is no, because normally you place a PQ from the contralateral side, you've got an aortofem there, you can't really get across. But the other thing is you need a patent inline common femoral artery. And here you don't have that. The femoral, the limb of the AFBG goes to the profunda, which really puts you at a disadvantage. It's a good, good to be thinking of all the options, and someday that'll be one of the options for something like this. But for now, no.
Yeah, it's easier for more straightforward anatomy. Aaron, you seem to agree. You're checking.
Yeah, I mean, the current PQ bypass system is 8 French and delivered through contralateral sheath. There are some workarounds where you can do it from antegrade access, but I think the lack of an inline direct flow from the common femoral is the real limitation here. With the PQ bypass, what you can do is you can tunnel down 40 to 50 millimeters past the origin of the SFA and then do the bypass into the vein. But I think given the prior surgical site at the common femoral on the left and the lack of a definite inline common femoral flow, it probably wouldn't be a good option.
All right, great. Let's keep going with the case.
Aaron, so most people have never done it.
Yeah, and actually, this is actually not something I did in fellowship either. I mean, this is a relatively
Is this something you did after spending some time in Germany?
Yeah, exactly. I actually did do this procedure a few times in Germany with some of the people in Leipzig. And I think it emphasizes for fellows too, that, your training doesn't end when fellowship ends. There's lots of options for hands-on courses, and new techniques will continue to develop. And there's really great ways to, stay on top of your game and open up better treatment options for patients as well. So, so this is just an example of, these are stills from when I was getting retrograde SFA access. This just demonstrates the angular approach that you want to get, where you're coming in at about at a relatively oblique angle, so you're not coming in too steep. And then when you spin around, and then this also shows the long micropuncture needle coming in through the Cook needle to show that it's keeping it from bending. And then spinning around at the other angle, you can see I initially was off with the needle a little bit off. So then you can just pull back and under fluoroscopic guidance or with a road map, aim for that target of the SFA. And then this is just a video here showing that in real time of getting the wire in. See if that's playing there. Yep, so just advancing the micropuncture needle. What I put in to do in these cases is that when I post
Fading in and out a
when
little
I get
bit.
that in access. Sorry, so I typically use a 1 centimeter tip Amplatz wire as the 035 wire in order to really make sure that the subsequent sheath I put in doesn't kink while getting into the arteriotomy. So subsequently, I went up with a wire. I used a straight stiff glide wire retrograde through a sheath and then a navicross. And actually, the wire went up, buckled, but got in a relatively reasonable plane that looked like it lined up with where I had a navicross from above from the radial access. And I actually did a hand injection through the retrograde navicross and through the antegrade navicross. And this actually demonstrated that I was actually true lumen. So I think what I would say here is probably better lucky than good with regards to the fact that the wire appeared to sail up through the occlusion and got in either through the graft hood itself that was jumped on the profunda, or I think may have actually just recanalized the native origin of the SFA and then reached into the common femoral. So let's see.
So so you had a sheath in there, Aaron?
Oh yeah. So I initially put in a 4 French sheath in the retrograde SFA. Typically I'll go 4 or 5 French with regards to. I think it skipped a step here. Hold on 1 second here. Yeah. So yeah, and but I've done 6 to 7 French sheaths as well in the retrograde SFA with pretty minimal concern with regards to that, because I think that you can generally get pretty good hemostasis with protamine and external compression. So now that I've crossed the lesion,
Aaron,
the question.
I have to say, you sure make it look easy. This is not easy. And he's just like, and there I go. I just flew across.
Because if it doesn't cross easily, so what was your backup plan? So you had the navicross all the way across it, and then so the question here about what system did you use to cross, and what would you do if the wire doesn't go in? And I think you're probably heading into some more exotic options that can make people cringe, like a sharp ureteric canalization or using some back end of wires and things like that. Is that what you had in mind, or if it didn't cross, you're going to just stop there?
No, I mean, I think it would depend on where I was as far as the no crossing. You know, if it looked like the support catheters were lining up close to one another, then probably what I would do is try to potentially use a Pioneer to re-enter. The advantage there is that, you know, with IVUS guidance, you can really make sure the needle's going in the right direction into the common femoral. You know, if that's not working and, you know, you feel fairly secure about the situation and want to really get this done endovascular, you know, people will use sometimes the back end of a straight stiff glide wire to see if they can re-enter. I've opened up a few of these where the native SFA have been ligated for one reason or another. And what that often requires is the back end of a straight stiff glide wire. Or I've done this once, and I know some other people have used, you know, like a Brockenbrow needle that you would typically use in order to really get a sharp recanalization. You know, that has some attendant risks, but, you know, it all depends on the patient clinical scenario and their need for the revascularization.
All right, thanks. So going back to the poll that you had up, which was
What you
do now.
So yeah, so the question would be, you know, what would be your next step after this? You know, would you go with an atherectomy followed by subsequent angioplasty approach? Just start with balloon angioplasty, maybe do primary stenting. It looks like the majority of the people voted for balloon angioplasty, and then atherectomy and primary stenting as other options as well.
Hey, Aaron, can you just make sure I understand the anatomy here? The aortofem limb is coming antegrade into the profunda, then flow is going retrograde in the profunda back up to the common femoral bifurcation, and then down the SFA that you just recanalized?
Yes, yeah, I believe so.
Okay.
Yeah.
It's kind of weird if the common femoral was open that they didn't use that for their aortofem. That's a little unusual. I mean, usually it's not like that. But that's a great example of that you, I mean, you're almost like an archaeologist on one of these cases. If you don't have all the facts, you have to be very open-minded about what they might have done, what could have happened. Sometimes on a case like this, the physician will ligate the proximal SFA if it's kind of a complicated femoral reconstruction. That can cause problems. And then the other thing is that if I were coming retrograde and I couldn't, you know, here you were lucky because the anatomy lined up that the common femoral was still patent. Most of the time when you go to the profunda, it's because the common femoral is not patent anymore. But you would know that also based on, you know, ultrasound and based on your pre-angiography. And lastly, I'll just say if I'm really struggling from retrograde, sometimes external ultrasound will help me, you know, right on the groin to help me watch the two wires coming from one direction or the other and help me realize that if I'm in a completely wrong place, ultrasound will show it pretty quickly usually.
Yeah, that's a really good point. It's so easy to visualize the common femoral right there with external ultrasound as well, that can be a nice technique for lining up any wires and really trying to assist the reentry, which would have been a good option here too if that hadn't gone through.
It's really interesting that you just didn't sail into that jump craft. You know, that seems like would be the most logical place, but obviously wires do different things.
Yeah, exactly. No, I was surprised as well, but it worked out relatively quickly here, and I'll save that for another day when things don't go as usual. But you know, in this case, I decided to use atherectomy as an initial debulking. Wouldn't it be reasonable to use balloon angioplasty? I was trying to go with a maximal vessel preparation approach and, you know, get the best possible luminal gain and minimize severe dissection. So I did use a jet stream. You know, this is a good rotational device that has an aspiration component as well. You know, it is a 7 French device, so this is a larger sheath that I put in the retrograde SFA, but I did use that to debulk. And then I subsequently used overlapping drug-coated balloons. I think these were 6x150 drug-coated balloons, 2 of them across the proximal SFA from the origin down. That's just showing the balloons being inflated at 8 atmospheres for 3 minutes each time. And then this is what that looked like afterwards. You can see that there's a channel. It looks like there's some recoil and maybe some dissection throughout the proximal, you know, 80 millimeters or so. but with a pretty good lumen and minimal recoil a little bit further down, which is not to be unexpected. I think probably there was some progression of disease and maybe a high remaining segment a little bit farther down within the SFA as well. That's just another picture of that, showing some of that recoil more proximally, but a pretty patent vessel distally. So my question then for everyone would be, use some overlapping drug-coated balloons here. There is some recoil and some dissection. What would you do here? Would you post-dilate with a larger balloon or for a longer period of time to try to tack down any dissection and minimize the recoil? Would you just leave it alone? There is antegrade flow now and use the drug-coated balloon. Or would you consider putting in some kind of a scaffold?
Yeah, well, I'm going to ask the panelists. I think it's freedom. I think you got, you're hooded on to the profunda and you're getting that retrograde flow through that. I think you got an option just to stent the thing, and I think it, give you the most durable result. But the rest, Peter, Vanita?
Yeah, I'd be kind of inclined as well, quite honestly, with that spot. I think it's possible. I would either leave it alone or do a stent. I'm not sure it would do much more with a larger balloon, but I think you're going to need to do something there.
Yeah, I think this is an art of medicine question for sure. We don't know. I'd be, also this is a kind of a complicated case with complicated anatomy. So, can the patient still lie still? Is the staff still with you? Are you having a hypoglycemic event yourself? It just depends on all those things. But everything else being equal, I'd be tempted to re-balloon it and just take a look. And of course, I know it's going to take extra time. And if I'm still not happy, then go ahead and scaffold. It's a little bit compromised. It's the fact that it comes down to the profunda, then retrograde, then down. Any future access is not going to be easy, or you're going to have to do something probably retrograde to get into it again. So I would try to do everything you're going to do now and try to get it as the most durable result you can. So if I didn't like the looks of it, I'd probably stent it at the end of the day.
So there's a few questions here. One is about using IVUS to help you size your balloon or stent. I think that's always a good idea. And you already have a big sheath here, so you can do that. Aaron, I don't know if you can speak to that. If you considered using IVUS to help you with sizing your balloons, or you just go by measurement. I think probably your access frozen, Aaron. But I think that's.
I agree. I think. Oh, sorry. I think IVUS is always helpful. I learn something every time I use IVUS. Honestly, I don't use IVUS that often in the SFA. I do tend to use across the tibial vessels, and gives you some confidence as far as going larger. But I think, IVUS here could have.
Yeah, your voice is
picking up a little bit there, Aaron. All right, so what'd you do, Aaron?
So in this case, I did try to dilate it further. I used a larger 6 millimeter balloon throughout here, post-dilated it, but there was still some significant recoil and dissection despite that, which isn't that surprising given that I had done a length of drug-coated balloon inflation. So in this case, I decided to just go ahead and stent that remaining area that had the recoil. And I put in a Supera. This was a 6x150 Supera. And, one thing about the Supera that's, interesting is, when you deploy it, you often can't tell exactly where the proximal end of the stent is going to end up, depending on how much you compress it or elongate it. But in this unique situation where we're coming retrograde and treating retrograde, you can actually, really nail where you want to land the stent proximally, and then, of course, it's going to end up being deployed distally. So this is just one point to make with regards to, placing this within the ostium of the SFA. And I intentionally landed the Supera a little bit back up into this hood here, just to really make sure that I didn't miss the ostium of that SFA. I thought that was the most reasonable approach for guaranteeing a good long-term patency in this case. Because I think, to Peter's point, getting here wasn't easy, and I wanted to try to make sure I was getting the most durable result possible as well.
There's a question about the profunda here, that there's a risk of profunda when you stent, close to the SFA origin with flush occlusions. What's your tactic there to make sure the profunda stays patent?
Yeah, I think that's always a really tricky question. I think generally in those cases, I try to minimize any stent overlap across the profunda origin. And what I do with that, sometimes I'll take some very strong views, with like a 60 to 70, ipsilateral view to really look for the origin, because I think conversely, I think one of the major causes of osteal SFA lesions occluding over time is that the true ostium was missed. And we have some advantages now with drug-coated balloons where we can hang a drug-coated balloon in the common femoral and probably at least cover that area with an anti-proliferative agent. So I think that can be very tricky to localize the stent exactly at the ostium.
But I think you're also a little bit protected because your graft is hooded onto the profunda, and you're getting, that the anatomy's a little strange, but I think if the graft is truly hooded onto the profunda and there was a jump graft, I think you're somewhat protected in this scenario versus, a true osteal kind of thing without having the inflow, being a concern.
Yeah, that's a really good point in this unique situation. And so this is what the final angiogram looked like with good overall expansion and brisk flow down the SFA. And then to complete the case, I gave 20 milligrams of protamine and applied a external cuff for about 15 minutes, and that was adequate to achieve hemostasis. And then we verified that with Doppler signals below the knee as well. And the patient continued to do well. This was about 1.5 years ago, and we followed him with serial duplexes, and we've not had any restenosis or occlusion.
Fantastic.
Really, really interesting case, Aaron.
Very nice. And this question about dual duplex therapy is what you gave him. Is that what you put him on?
Yeah, when I did this case, I put him on dual antiplatelet therapy for 3 months and then just aspirin monotherapy, which is my routine for most endovascular interventions. Honestly, if I was doing this case today, and I think increasingly I'm using rivaroxaban especially for these people with more complex PAD, where we're worried about the risk of occlusion. As we know, that has shown a reduction in acute limb ischemia. And I think that with these patients with more complex disease, anatomic perspective.
Faded out a little bit, Aaron, but it sounds like you're using rivaroxaban, which is I think we're all starting to use a bit more. And the question is it just rivaroxaban and aspirin? Are you doing Plavix as well? What is the rest of the panel doing or going to be doing?
That's going to be tough. We don't have the answer to that yet. The void was just published, so
yeah,
we'll see. I mean, it's probably going to be maybe all three for a short period, then just aspirin and rivaroxaban. But we don't know yet. All right. Since in the interest of time, Peter, let's go to your case. And thanks, Aaron. That was excellent. So, Peter, if you share your screen, perfect. We see it. Go ahead.
Yeah, I was just going to say, within a couple of weeks ago with VIVA, we did a little webinar on the Voyager trial with the PI Mark Banaka, and that's on the web somewhere. But this is where the latest data comes from on this rivaroxaban discussion. Now, on time-wise, are we going to the top of the hour?
Yes.
Okay. So we wanted to have, you've already seen now in these cases, the first case we discussed retrograde access. In the second case, Aaron got retrograde access. So any kind of discussion about CLTI revascularization now is going to involve retrograde access. And I just put this here briefly as a laundry list for the fellows of kind of each of these has a decision tree associated with it. And you hear a lot of this stuff being touched on in the course of just seeing these 3 cases. But this is a kind of a thing where if you have this list for yourself, for your own practice, and you start to fill in, okay, I like this needle, or I like that wire, or that catheter, I like this angulation of image, et cetera, et cetera. I like this puncture site for that problem. And so this is kind of your laundry list. And here's your patient. So 68-year-old man, so relatively young, left great toe ulcer, diabetes, coronary disease, has a history of mild claudication. Many diabetics, as you know, don't have a history of claudication and come initially with tissue loss as their first story that you hear. He's got a left great toe lesion, which you can see. It doesn't look super healthy, but it also doesn't look too deep or too big. You can see a little hint of granulation there. His toe pressure is 35 millimeters of mercury, but the toe pressure, to be fair, is on the second toe, not the first toe, because he's got the first toe lesion. So second toe, you know, toe pressure, you typically have to figure out might be a few points lower. You know, nobody's really looked at that, but I don't think you can assume. I looked at this and I looked at him and I thought, he's probably going to heal that. It's a small medial toe ulcer. He's got a borderline toe pressure on his second toe. And his duplex shows an SFA stenosis and occlusion of the popliteal artery. So I thought he was going to heal it. He wasn't too excited about intervention, or at least I thought he had a chance of healing it. And after a couple of weeks, it really wasn't going anywhere. So went ahead and did this angio. Now, in this case, normally when I'm dealing with a popliteal occlusion or tibial work, I like to go antegrade whenever I can. And you can see that although his common femoral was relatively okay, he's got some proximal SFA disease, which maybe with a CTA or MRA, I would have said that's okay for antegrade. But with duplex, I couldn't really tell because he had that lesion in the proximal SFA. So I went up and over here and you can see relatively focal, relatively severe lesion of proximal SFA. Rest of the SFA looks pretty good. He gets down to the P2, P3 junction, and he's got a popliteal occlusion. Also, let me just point out that you can see where my sheath is. So that tells you something about the cadence of events here and what I'm thinking. But just to look at the rest of the imaging, you can see he's moving around a little bit, but you really do want, to the extent that you can get it, an AP and lateral. I knew he had 2-vessel runoff, but I wasn't exactly sure about foot perfusion with all of his wiggling around. So on the way in, I treat the proximal lesion. It's inflow for a popliteal occlusion. So I want to make sure the integrity of the repair is as good as I can get it. So I go ahead and opt for a stent. And now you can see again where the tip of my sheath is as I'm approaching this lesion. I've got my little angled tip wire here, and I'm hoping to drill right through it. And the challenge is, you know, with all of these is it's this rich perigenicular collateral network that's keeping the lower leg and foot alive. And there are also places where your wire preferentially wants to go instead of across the popliteal occlusion. It's sort of like the difference between going downriver and going upriver. You're going upriver, it's a lot easier to find the source than if you're going downriver and you're trying to figure out what's going on. And that's the exact case here. So when you're crossing an occlusion in this location, I like to have proximity of the sheath. I like to have, you know, this is, you know, my choice of CTO catheter. You saw a Navicross work. I think you've heard a Quick Cross mentioned. Very often I use a CXI because you've got a telescoping ability between the 4 French and the 2 French versions. Everybody has their go-to wires for CTOs. In the past couple of years, a Command 014 has become mine. If it's heavily calcific, I might use a Command 018. I use it for this purpose. I like to create a bent tip, you know, a little bent tip on the Command because you don't typically destroy the wire while you're doing that. Many of the other wires, you kind of have to destroy a couple to get the tip shaped the way you want it. So I bend the tip in a relatively acute angle with the idea in my head that I'm going to drill across it. And I do 3 to 5 rotations in one direction and 3 to 5 in the other. I'm not really pushing too hard, just very gently. And I'm watching to see if the wire makes progress. And this is what I got, which is, it's not anything to fret about because the 99.9% of these don't go anywhere except that they prevent you from seeing where you want to go. And this is usually the byproduct of me trying too hard from an antegrade direction. So in this case, here's a pole, and I'll just, and this is really, I mean, there's a lot to retrograde access. But one of my key learnings, and there's no right answer to this question, by the way, but I'll just read it. How do you decide to convert from an antegrade approach alone to add a retrograde approach? Set a time limit for an antegrade approach to cross, and if that's exceeded, just add your retrograde. Assume that if it's a BTK occlusion, that a retrograde approach will be required. Only add a retrograde if there is a complication from the antegrade direction. And then the last choice is start every CLTI patient with a retrograde approach. Anybody on the panel have any strong feelings about that? Sar, you published on retrograde approach and your results when you were at UVA. You're a pro. When do you pull it into the mix?
Yeah, I would say that whenever I see this occlusion of the distal pop with a trifurcation and I don't see the origins of the tibial arteries, that's almost guaranteed a retrograde approach. So whenever I see that, I just prep the foot because I know that chance of crossing antegrade is very low. I still give it a try from antegrade, but I know that I'm going to be stuck in all these collaterals. But to me, that's probably the biggest predictor. This picture that you have, which is a popliteal occlusion involving the origins of all the tibials, is the one that definitely will need a retrograde.
Yeah, so I'm right there with you, and I see Vanita's got phone a friend there going on, so she's got unfair advantage. She's getting help from the outside, but I'll just say what I learned this the hard way. I learned it the hard way that you don't want to wait until you're exhausted, the patient can't lie still anymore, and you're not at your best when you're doing sometimes the little bit trickier part of the case. So that's why I set a time limit. And if I don't typically cross, and sometimes it magically goes across, it's not as bad as you thought and it just sails across. But very often Saher's method is exactly right, that you see that anatomy and you say, you know, I'm probably going to have to puncture the ankle, and you don't want to prolong the agony if you're at that, if that's what you're thinking. Vanita, what do you think?
Yeah, I absolutely. And I actually think what I've started to do with these CLI patients that I know is going to be a tough case, I first of all sort of have this whole setup where I flip them so you can go antegrade and the wires are going off towards their, off their head, so you're right-handed. And then I just prep the foot always. And that way, that like little bit more of inertia of like to go retrograde or prep the leg, that's out. It's already there. It's ready to go. So if I'm struggling for too long, I just head over there.
It's almost like prepping the foot is kind of like calling for the TPA. It's a threat. And so because of that, sometimes you don't have to use it. In any event, we want to let people go. It's getting late on a Friday. Let me just cut to the chase here. So as Sars suggested and Vanita suggested, we did do a retrograde puncture. He had a nice PTA or posterior tibial for that. In this case, my retrograde wire is usually a V18, interestingly enough, different than the command that I might use from above. It forms a knuckle nicely. It's got a good column strength in case you got wire alone. And going upstream, it's easier to find the source. And so here you see the wire coming up. You can see where it crosses, we get it across the occlusion. We cannulate the tip of the angled shaped tip catheter from above and externalize the wire. And then we go to work. And the go into work part is not as important because you have lots of different ways that you can reconstruct things. For me, the important things are it is popliteal, so that's special considerations. It's inflow for a CLTI lesion, that's special. But the other thing that's notable here, and I'll just mention super important, maybe more important than how you reconstruct it, is that you really do want to preserve those perigenicular collaterals. So when you do the rendezvous, when you make the two wires meet, it's got to be along the course of the occluded segment. If you make the two wires meet above or the two wires meet below, you're going to be excluding some of that collateral network. And so that's the key. And just bringing it to a close here, I end up putting a stent that he has way better runoff than I thought on my initial angiogram. At the end of the day, he's got now what I would call a pretty severe dissection of his TP trunk, and it's his posterior tibial that I'm most interested in. So in this case, I used a coronary DES. I probably would have used a TAC now since that's approved. Either way is fine. And the main thing is to have a high integrity reconstruction since the patient is relying on this to heal the foot. So, and that was my last slide. So any other advice about this? Any other advice? My hope was to just highlight retrograde, but you can see that when we started talking retrograde, we were primarily talking pedal. But now any artery distal to the groin is fair game for a retrograde puncture. And one thing that I've started to do a lot of that I didn't do at first is to puncture a dead artery. So, and I think Sarah might have already alluded or mentioned this, that, you know, if I've got an AT or a PT occlusion and I've got the other vessels are open and I've got my choice of where to puncture distal to an occlusion, sometimes puncturing an already occluded artery is a great way to, you know, absolutely limit any risk to the patient and still get across your occlusion that would be above your distal puncture site. So any, I know there's lots of tips and tricks, and in 90 seconds left, I don't know how to impart those, but
this was a fantastic case, Peter, but just to quickly hear about your access to retrograde. Do you put a sheath or do you keep just a catheter? And what stent did you use?
Yeah, so I'm a vascular surgery purist. So I was not the first person to adopt a retrograde puncture approach. Watching it unfold, I've gradually convinced myself that it's actually quite safe. It's really rare, I think, when you lose a puncture site. Nevertheless, I think losing a puncture site is dependent on two things: a technical, either ultrasound or fluoroscopically guided puncture, but also how you manage it after that. So if I can avoid a sheath, I do. I would say I probably only, for me personally, I use retrograde to cross lesions. I don't usually use it to treat. Other people will show us the way, not me, but I know a lot of people are using it for treatment, for the specific reason to go ahead and treat an SFA or pop through the ankle, which I don't do, but that of course would necessitate a sheath. I probably would go as large as a 4 French sheath, and I probably only need it on 10% of my cases. Only when an occlusion is recalcitrant, I need more pushability, I need to advance a balloon for a cart technique, advancing a balloon from below. It's nice to have a little sheath. That way you can administer, you know, antispasmodic, et cetera, right, you know, into the ankle area. How about you?
That same, I just usually keep the inner of the micropuncture or just put just a CXI retrograde and try to do all the work that way. Rarely need to use anything bigger than that. And even less than 10%, unless it's primary pedal case, which is rare.
Yeah, Peter, I bet you your time now that you try to approach it from an antegrade has become shorter and shorter as you move along. You know, and I think that's one of the things that we all think about is that these cases can get pretty long. So I think after you've failed a few times or not been successful going antegrade, I bet you your times now, you look at something, you probably, like as you and Sarah are saying, you may just look at something and say, this is just best approached, but give it a poke or two.
I will say one thing just worth mentioning briefly is that I've used retrograde puncture less for occlusions of the tibial artery only. So in other words, the wires have gotten so good, the support has gotten so good, our judgment about how to access from antegrade has gotten smart enough that most of the time, coming from an antegrade direction, I can get across a tibial. So retrograde puncture for tibial only recanalization has gone down, but retrograde for those popliteals like that, as Sarah pointed out, you see that anatomy and you just know you could sample each one of those collaterals before you ever come close to finding the right place. That's where, if anything, it's gone up. And like Nitin, like what you said, my time limit now has gone down progressively from wait until I'm exhausted to, okay, I'll give it a try for 1 minute. And if that doesn't work, I'm going retrograde. And it's kind of more like that.
All right, this is great. I think we're getting to the top of the hour here. So thanks a lot for our panelists. Thanks. I mean, this has been fantastic to share your experience with the fellows. I'm sure they really appreciate it at this time. Just a reminder that this event has been recorded and will be posted on the VIVA Physicians website in a few days. So you can check the www.vivaphysicians.org. Thanks a lot for participating in our special CLI webinar. And don't forget to subscribe to the VIVA newsletter. And for future VIVA events, we're going to have more of these events for the fellows in the future. So just be on the lookout for that. And you can go to the vivaphysicians.org and sign up for the newsletter to know when the next one is, or follow on Twitter. Thanks everybody for being here with us, and everyone please stay safe. Thank you.
Yeah, take the rest of the day off.
Thank you. Bye, guys.
Bye.
Hey.